Good evening, and thanks for joining me as we talk about biologics for chronic rhinosinusitis with nasal polyps, the who, when, why, and which one. I want to let you know that this activity, which you know is for CME, is provided by Integrity Continuing Education Incorporated, and it's supported by an independent medical education grant from Regeneron Pharmaceuticals Incorporated and Sanofi. I'm Dr. Michael Blaiss. I'm a clinical professor at the Medical College of Georgia at Augusta University in Augusta, Georgia, and I'm happy to be here to present to you this evening on this important subject. These are my disclosures for this particular lecture. And I have three learning objectives for you this evening. One is, how do we incorporate a patient-centric focus into evaluating the physical, extranasal, and psychosocial aspects of disease burden for each patient we see with chronic rhinosinusitis with nasal polyps. We also want to elucidate the best practice criteria for recommending sinus surgery or biologic therapy, or when corticosteroids may or may not be appropriate for these patients. And lastly, and importantly, is with the data we have to differentiate between the new and emerging biologic treatments for this condition using data from clinical trials and other analysis. So let's start by first understanding the disease burden of that patient we see with chronic rhinosinusitis with nasal polyps. And this is a very interesting study from Hall, and this interviewed 27 patients in the United States and Germany that in fact had severe nasal polyps. And they looked at the impact by what's called proximal and distal impact. So when we talk about proximal, it's directly what in fact is happening to the patient related to the nasal polyp symptoms. So you see things here like sleep impact and physical functioning, nighttime awakenings. And you can see the vast majority of the patients with severe nasal polyposis had these problems. And then we had the distal impact, which really kind of looks at the patient's total quality of life, like emotional well-being and social life and work, feeling annoyed. And you can see here, especially if you look at emotional well-being, 27 out of 27 reported that this condition caused that problem, and 26 out of 27, in fact, an effect on their social life. Now, what's usually used in clinical studies in patients with chronic rhinosinusitis with nasal polyps are some questionnaires to look specifically at quality of life related to sinonasal symptoms, or generic that looks at the general impact on the patient's quality of life. So the ones we use for disease specific, and you may be familiar with these from clinical studies, probably the most common one used in the United States is the SNOT-22, the Sinonasal Outcome Test 22. There's also the Chronic Sinus Survey, and one we use a lot primarily for allergic rhinitis, and that's the Rhinoconjunctivitis Quality of Life Questionnaire. Now, there are many questionnaires out there that are generic in the sense that they measure quality of life no matter what the disease state or condition is. And the gold standard is the Medical Outcome Study SF-36, or short form 36, which has been standardized and used throughout the world as a gold standard as far as measuring quality of life. The EQ-5D comes to us out of Europe, and then there's a global well-being survey. So these can help us in really looking at the true impact of nasal polyps in the patient population. But they're not easy to use, especially in a clinic situation. And that leads us to this particular survey that was developed by Dr. Bruce Tan. It's a short 12-item survey asking the patients how their chronic rhinosinusitis has been affecting them over the last 7 days. So it's something that could be quickly done in an office setting. And the good thing is they've gone through validation studies, and it does validate highly with the SNOT-22. So this is something that I think should be used in more and more clinics to really get an idea of the suffering that our patients are having with this condition. One of the things that's clear is this is a very expensive medical condition. And it's estimated that the total economic cost per year in the United States gets close to $6 billion. And there's high indirect cost. That means missing work, decreased productivity at work. And in fact, it's estimated there's almost 5 days of missed work per year in patients that suffer with this condition. And the costs are thought to be almost $7,200 per year for patients that, in fact, have this condition related to indirect cost. So when we look at the total cost in the patient population per year, each patient, it's over $15,000. Now, one of the things that many of us that take care of these patients realize is that there can be lots of comorbidities associated in our patients with chronic rhinosinusitis with nasal polyps. And these are type 2 conditions that are commonly seen in the population. Things like aspirin or NSAID exacerbatory respiratory disease, asthma, allergic rhinitis. And as we'll see from some of the data, patients that have chronic rhinosinusitis with nasal polyps and one of these type 2 comorbidities tend to have more severe disease. So these seem to be some of the worst patients, in fact, that we take care of with this problem. And this is illustrated in this particular study published this year by Hopkins in Rhiology. And what they did here is they looked at the 10-year probability of revision in a patient who had, again, sinus surgery. So what was their 10-year probability of a revision? And they looked at the differences whether they had comorbid conditions like asthma or they did not. And the bottom line is the ones with comorbid conditions, the revision rate was anywhere from 71 to 90%. It was only 51% for the non-comorbid patients. So if these patients with chronic rhinosinusitis nasal polyps have a comorbid condition, they're almost 5 times more likely to need a revision surgery in that 10-year period. That's something really to think about. So what I'd like to do now is move on and spend a few minutes talking about pathogenic and molecular drivers in this condition. And we tend to divide chronic rhinosinusitis into 3 major inflammatory endotypes. Now, type 1 is primarily chronic rhinosinusitis without nasal polyps. In fact, this is the most common. It occurs in about 80% of the patient population that has chronic rhinosinusitis. Obviously, the other 20% is the group with polyps. This is primarily seen in females more than males. And as you can see here, the typical effector cells include the Th1 cell, the NK cell, with the primary cytokines interferon gamma and IL-12. The group that we're primarily dealing with tonight is the type 2 condition, because these are the ones that have, in most cases, the nasal polyps. And this is what we see in both the African American and Caucasian population. And like other type 2 conditions, we see, again, the involvement of eosinophils, Th2 cells, and type 2 innate lymphocytes and mast cells, and then the type 2 cytokines, IL-4, IL-5, and IL-13. Now, the third group is the smallest number, and that's the type 3. And there are patients that have with and without nasal polyps. There's a group without nasal polyps. And again, this is primarily neutrophilic driven with IL-17, IL-22. It's interesting to note that the Asian population with nasal polyps tends to have a higher level of type 3 inflammation than type 2 inflammation. Now, this is looking at the immunopathology of the condition and the current therapeutic targets. And so we're dealing with the epithelium, and you can see it's getting bombarded here with numerous different fungi and irritants and bacteria. This can activate the epithelial alarmins. So one of the targets now are things like TSLP, IL-33. We could include IL-25 there. And then this can then drive or help drive both the adaptive and the innate immune system related to type 2 disease. And this is where we have a lot of interaction with the type 2 cytokines, IL-4, IL-5, and IL-13. And again, the targets there as far as blocking those cytokines to, in fact, block the inflammation. You'll also notice on this slide CRTH2 receptor, which is found on a lot of different cells that are involved in this condition. Unfortunately, so far, none of the treatments that have been developed to block this particular receptor have been very beneficial in any type of type 2 disease. So let's start with a patient here. Here's our friend John, and he comes to us with a history of postnasal drip, decreased smell, and sinus pressure and pain. He was diagnosed with asthma in his mid-20s, and he says recently he's had some rhinorrhea, he's had a seasonal cold, and current medications include over-the-counter nasal steroids that he uses for symptomatic relief, so just as needed over the past 2 years. And for his asthma, he's on a low-dose inhaled corticosteroid. Endoscopy showed the presence, though, of nasal polyps. So here we have our first question for the evening. Want to get your response. John's clinician orders a CT of the paranasal sinuses and schedules follow-up in 30 days. So how would you treat John? Prescribe intranasal steroids for regular use, prescribe short-course oral corticosteroids and recommend regular intranasal steroid, refer for evaluation of functional endoscopic sinus surgery, or initiate biologic therapy. So let's see your answers now. All right, so the answer that got the top response is prescribe short-course oral corticosteroids and recommend regular intranasal steroids. I think that is appropriate for this particular patient. He has not yet been on what we would consider a standard of care therapy. So with that, let's talk about medical management of these patients with chronic rhinosinusitis with nasal polyps. And we always start, as I would start with John, is in fact with standard of care therapy. And the gold standard is starting intranasal corticosteroids. We know that there are numerous ones over the counter. In fact, Mepolizumab just got released over the counter. There's also a prescription, which in fact is the exhalation delivery system with Fluticasone. Off-label, we can use things like nasal drops, nasal instillations, and that's done by some clinicians. Some patients may, in fact, need oral corticosteroids. We use these basically what we call a medical polypectomy. They'll lead to very acute relief of severe blockage. They'll improve that loss of sense of smell. But as all of us know, oral corticosteroids can have significant side effects. So obviously we don't want to use on a regular basis, especially not for long-term use. And there's even data, as we'll see, that burst of oral corticosteroids can be accumulative and cause steroid side effects. Also, I think very beneficial is saline irrigation, especially large volume, hypertonic. And if, in fact, one thinks that there is a bacterial infection, an antibiotic would be appropriate. So I think we have to remember in most of the cases with chronic rhinosinusitis with nasal polyps, we see it's not a bacterial condition. So this is the exhalation delivery system with Fluticasone. And the way this works, and if you look at the diagram, there is where one puts in the nose, and then there is a mouthpiece and a mouthpiece. And what one does is blows into the device. This leads to the soft palate closing. This therefore increases the pressure in the sinonasal cavity, and therefore what the hope is that will lead to better distribution of the Fluticasone into the posterior nasal cavity. This was approved by the FDA a few years ago in patients with moderate to severe chronic rhinosinusitis nasal polyps. In the phase 3 study, they showed elimination of the polyps in at least 25% of the patients on one side compared to placebo. There was a significant improvement in SNOT-22 and a significant decrease in the need for surgery. So this is also definitely an option for someone like John. Now, what happens if these types of things are not controlling the problem? Then we may want to think about management with surgery. Obviously, it gives acute relief also as far as the severe nasal congestion, removing the polyps. It's important to note, and this goes for every treatment we're talking about tonight, none of these treatments cure the condition. They help to control the condition. And when patients have had sinus surgery, it's extremely important that they get back on their intranasal corticosteroids to try to prevent nasal polyp regrowth. Now, in patients who have had surgery, but now are having symptomatology again, one could also use a steroid-eluting implant stent. This was approved by the FDA a few years ago. It delivers mometasone to the ethmoid sinus over about a 90-day period. It can be placed in an office setting, and it's been shown to be effective as far as decreasing the need for revision surgery. So let's come back to John again with another point here. So he was given that short course of oral steroids, and that was given to him after he got the CT, and then started on regular intranasal steroids. But John reports oral steroids relieved his symptoms, but the symptoms have returned in the last week, so about 2 weeks after stopping the oral steroids. He tells us that he has been using his Fluticasone daily, and his CT scan showed bilateral nasal polyps with moderate opacification. So that leads us to our next question, and that is, John is presented with the following options for a trial of therapy. Which therapy would you recommend? Would you prescribe the exhalation delivery system Fluticasone? Prescribe oral corticosteroids again? Refer for evaluation of functional endoscopic sinus surgery? Initiate biologic therapy? So the majority of you would prescribe the EDS Fluticasone. Others would evaluate for surgery. In fact, I think that one could definitely try the Fluticasone in the exhalation delivery system again, and see if that would control the problem. And I think that most of us would try to do something like that before referring for surgery. But again, we'd have to watch and see how he does. The good news here is none of you said to prescribe low-dose oral corticosteroids again. And I do think we have to be very careful as far as how often we're giving bursts of oral corticosteroids. So this is a study by David Price. It was done in asthmatics. Adult asthmatics who required a steroid burst and none, and then another episode needing steroids within 18 months, and then a group of asthmatics that they were matched with that did not require steroids and none over 18 months. And they followed these patients retrospectively from the data over about an 8 to 9 year period. And they looked at the cumulative effect of oral corticosteroids and the development of steroid side effects. And as you can see here on the bar graph, as few as 4 to 5 bursts of oral corticosteroid over that 8 to 9 year period, in fact, led to significant increase in steroid side effects. So we know that problems can occur with daily, alternate day, but we also have to remember that short bursts of steroids also have a cumulative effect and can lead to unwanted side effects. So let's move on and talk some about biologics and why we would consider these treatments for our patients with chronic rhinosinusitis with nasal polyps. So these are the 3 approved by the FDA, and we're taking them in the order of approval by the FDA. So first is dupilumab. We know that it targets IL-4 and IL-13. Its indication is add-on maintenance for adults with uncontrolled chronic rhinosinusitis with nasal polyps. You can see that it's dosed sub-Q every 2 weeks. There were 2 phase 3 studies, and we'll look at the results of all these phase 3 studies. One that was 24 weeks, the other was 52 weeks. Next approval was Omalizumab, which targets IgE. It has on its indication add-on maintenance for adults with inadequate response to intranasal corticosteroids for nasal polyps. It's dosed as we dose for asthma. So it's based on body weight and serum IgE level. So that's why you see that dosing range there. It had 2 phase 3 studies, both were 26 weeks. And the drug that was approved most recently, Mepolizumab, which affects IL-5, is also approved for add-on maintenance treatment for adults 18 and older with chronic rhinosinusitis and nasal polyps. It's given sub-Q every 4 weeks, and it was approved on one basically 52-week study. So let's kind of look at the results. I will say, as you see in the red there, that when one has looked at the safety of these agents, and again, all of these agents have been approved for other conditions before nasal polyps, the safety of these all are pretty equivalent. So the primary endpoint in these studies, it's a co-primary endpoint. The first endpoint is nasal polyp score, which is scored from 0 to 4 on each side. 0 is no polyps, 4 are polyps coming below the inferior turbinate. All the patients in the 3 drugs I'm going to talk about this evening, biologics, had to have scores of at least 5 to participate in the study. And then the second of the co-primary endpoints is the nasal congestion score, which is usually scored 0 to 3, 0 being no congestion, 3 being severe congestion, to the point that the patient cannot tolerate it. So what we're looking at here with dupilumab is the results of those 2 co-primary endpoints, nasal polyp score and nasal congestion. And if we look at nasal polyp score for both 24 weeks and 52 weeks with dupilumab, if we look at a 2-point improvement, remember the highest would be 8 points, which a 2-point improvement is a great deal of clinical improvement. 1 point is a mild to moderate improvement. You can see it was 46% with dupilumab, only 5% with placebo. In the 24-week study, in the 52-week study, it was 46% with dupilumab, 1% with placebo. So it showed excellent effect. And if we look at nasal congestion score, there was also significant improvement in both studies as far as improving nasal congestion. Now, they also looked at the need for oral corticosteroid burst and or surgery over that 52-week period. So this is a pooled analysis of the 2 studies. And what you can see here, 41.8% of the patients on placebo either required oral steroids or surgery versus only 12.5% of the group that got dupilumab. And you can see that that was highly statistically significant. Now, let's move on to Omalizumab. They did 2 26-week studies. And what we're looking at here is Polyp 1, Polyp 2. So that was the primary study. And for both of these, for nasal polyp score, nasal congestion score, there was significant improvement with Omalizumab compared to placebo. Then if we look at the OLE treatment period, they switched the patients that did not get Omalizumab onto Omalizumab. And you can see here again the improvement those patients had. And then they took them all off their medications at 52 weeks, and you'll notice the condition worsening again. So it's important to note that biologics are a chronic treatment that if one stops the treatment, the symptomatology, in fact, can come back. Now, they also looked at reducing the need for surgery with omalizumab. So what they looked at in both studies is reduction for need for surgery, how much improvement there was in the nasal polyp score and their SNOT-22. And what you can see here is that there was significant reduction in need for surgery in both studies with omalizumab. And then the third agent is Mepolizumab. And as we mentioned, this is a 52-week study. You're kind of looking at the data a little differently here, but the bottom line is for both nasal polyp score and for nasal congestion, there was statistically significant improvement at the primary endpoint with Mepolizumab than what was seen with placebo. And if we look at their reduction as far as need for surgery, it was also statistically significant. You'll notice here for the placebo, it was around 22 to 23%. It was about 9% with Mepolizumab, and you can see the significant p-value that was demonstrated with Mepolizumab. Now, there are also agents that are in clinical trials, and we'll have to see how the results go. First is benzarilumab. And you'll notice the Astra study finished in July 2020. So in fact, it has been published. They did go to the FDA for this particular product. It did make its primary endpoints, nasal polyp score, nasal congestion, but not to the degree that was seen with the other agents. Also, it did not show significance in all the secondary endpoints. So the FDA did not approve this agent at this time. They said that they're going to wait for the second study you can see here to see the results. So we'll have to wait on benzarilumab. There's also data studies ongoing with tezepelumab, which blocks TSLP, and also an agent that has not been approved for anything as yet, and that's depinokinumab. And this is a long-acting anti-IL-5 agent, which is under study for polyps, with dosing basically being, because of its long half-life, about every 6 months. So interesting things in the pipeline. We'll have to wait and see what the results are and see if these are approved over time by the FDA. So we'll come to some important questions related to biologic treatments, and that is, who do we put them on and when do we use them? So there have been a lot of published algorithms to try to help us as far as determining what is the next proper treatment in our patients with chronic rhinosinusitis with nasal polyps that have failed standard of care therapy. So this is a paper by Joe Hahn. It had otolaryngologist on it. It had allergist on it. It had pulmonologist on it. And they came up with the multidisciplinary management algorithm. You'll notice here that it talks for a majority of the patients, they would go to sinus surgery first, and then go back to standard of care with intranasal steroids. And then if things reoccurred, they give the options here of things like biologics, revision surgery, aspirin desensitization if the patient has, obviously, aspirin sensitivity, steroid sinus implant because they've had surgery already, or consider a short burst of oral steroids. And then they talk about a minority of patients, if there's a contraindication to surgery, or they have poorly controlled asthma, steroid-dependent asthma, or they just decline surgery, and then start with a biologic. So there's some differences of opinion here. I think we should be using shared decision-making at the very beginning and give the patient the option, basically, for all of these things and see what their buy-in is related to the treatment. But this is one algorithm out there. Here's another algorithm that comes to us from Euphoria, which is the European group on allergy and airways disease. And it's made up of different specialties, including ENT and allergy in Europe. And here's their indications for biologic treatment. One is to have the presence of bilateral nasal polyps, and they determine the criteria based on if you've already had surgery or you've never had surgery. So if you've had surgery, 3 of the criteria below. If you've not had surgery, 4. So what are these 5 criteria? Evidence of type 2 inflammation, need for systemic corticosteroids, 2 or more bursts in the last year, significant impairment of quality of life, significant loss of smell, and diagnosis of comorbid asthma. And I think, these at least are more toward my thoughts. And then this one comes to us from EPOS. And EPOS is the European position paper on rhinosinusitis and nasal polyps. And this is primarily from otolaryngologists. So this is their criteria for starting biologic. It's in patients who, in fact, have failed endoscopic sinus surgery, and they have 3 of the 5 criteria that we mentioned. So you can see there are some definite differences of opinion when biologic treatments are started. So let's come back to our patient, John. So what will we do next here? So if we use the multidisciplinary consensus paper that we mentioned by Joe Hahn, he's a candidate for surgery unless there's some reason we don't know that there's a contraindication, or he just completely declines it, which I think patients should have that right. Euphoria, he does meet the criteria for biologic because he does have comorbid asthma, loss of smell, need for steroids. He definitely has type 2 disease. And EPOS, he does not qualify for a biologic yet because, in fact, he has not had surgery. But I think this gets back to something I'm very passionate about, and that's shared decision-making, that each patient should have the different options, the pros, the cons, the outcomes, the cost, and get their take on what they think may be the best for them. Because patients that go through shared decision-making tend to be more adherent to treatment since they, in fact, had a stake in that treatment. So I think this is an excellent condition where we should be doing that. Now, what about surgery? And so in patients that are on standard care therapy, what we see pretty much through the literature is about half fail. So this is from data coming to us primarily from Europe and from the UK, from a study that was done by Galen, which is the Global Allergy and Asthma European Network. About 46% of patients that, in fact, with chronic rhinosinusitis nasal polyps do require surgery. And then there are several studies with follow-up, and we know that polyps can really reoccur, especially if they have comorbidities, as we mentioned. So in a couple of studies, they found a recurrence rate up to 40% in patients at 18 months, and a very long-term study out of Europe showed that about a third required repeat surgery over 12 years. And in fact, 1 out of 5 had multiple surgeries. So that's something to think about. So as we move on to talk about biologic treatments, which one? Now, the first thing I want to mention is at this point in time, there are no studies that have been published of head-to-head studies between the different biologics. So no one can tell you with absolute certain which particular biologic is the best. So what is done is different types of meta-analysis looking at the different phase 3 studies that have been done. But I always tell people you have to take this with a little grain of salt because the criteria in each of these studies of the patients is not identical. So they're not exactly identical type of patients. Nevertheless, we have several analyses that have been done. This was one done in Europe that, in fact, looked at the data from dupilumab, omalizumab, and mepolizumab. And the bottom line here, when they analyze the data, we look at improvement in smell and quality of life and decreased need for steroids and surgery. There was a definite benefit seen with dupilumab compared to the other 2 products. Now, this is from Anja Peters in the United States. This is an indirect meta-analysis. So again, we don't have head-to-head studies. So what we're taking is the data that we have and analyzing it And here we're looking at nasal polyp score, nasal congestion score, and loss of sense of smell. And what you'll notice in this indirect meta-analysis is that the studies tended to favor the results with dupilumab over omalizumab. So let's move on to this particular patient. This is Susan, a 34-year-old female, and she comes to us with a diagnosis of chronic rhinosinusitis with nasal polyps and reports loss of smell over the last 3 months. And she has nasal polyps. It's confirmed by doing endoscopy. She has comorbid asthma. It's controlled with a budesonide inhaler. She's already had 2 functional endoscopic sinus surgeries and 2 courses of prednisone in the last 18 months. And she tells us that she gets really minimal benefit from intranasal corticosteroids. She mentions how her sinuses got real bad when she took ibuprofen recently because she had foot surgery. And she had to increase the use of her rescue asthma inhaler. And she requests another course of prednisone, because that's the only thing that seems to help. So that leads us to our next question. How would you treat this patient? A short course of oral corticosteroids, revision into functional endoscopic sinus surgery, biologic treatment, a short course of oral corticosteroids plus revision endoscopic sinus surgery or biologic, steroid sinus implant, aspirin desensitization. So if I could have your answer now. Okay. So, yep, these are the 2 answers that I would give. And I think, part of this, again, gets back to shared decision-making. There's not an absolute right or wrong. One could be a short course of oral steroids and then revision endoscopic sinus surgery or biologic. Aspirin desensitization is definitely a possibility. I would also put in this list strongly is just biologic treatment alone. But I think giving a steroid burst is probably going to be needed because she's suffering so much. So there definitely are some good options here to be discussed with the patient. So if we go back to those algorithms that we mentioned previously, does Susan, in fact, qualify for a biologic therapy? So if we look at the multidisciplinary consensus, she definitely does because she has had surgery and she's still having, again, the different symptomatology that we mentioned. So biologic could be there, revision surgery, again, aspirin desensitization, steroid implant, short burst oral steroids. All of those things could be discussed with her shared decision-making. If we look at euphoria criteria, she definitely meets that criteria for a biologic, for oral steroids, or comorbid asthma, loss of smell. And also, she qualifies for biologic from the EPOS criteria because, again, she's had surgery, she has comorbid asthma, she has a loss of smell, and she's had 2 or more bursts of oral steroids in the last year. So again, very important patient again to go to shared decision-making with her condition. Now, we're going to go back and look at another indirect meta-analysis. And again, this is not from a head-to-head study. But what we're looking at here is a subgroup analysis of the patients with chronic rhinosinusitis with nasal polyps and asthma. And so we're looking at one subgroup, it has asthma with or without aspirin sensitivity, and then a group with aspirin sensitivity. And for both groups, again, in this direct and indirect analysis, the data suggested there was a better improvement with dupilumab for both nasal polyp score and nasal congestion score than what was seen with omalizumab. So we have some very important key takeaways for this evening. And one of the major takeaways that I want to cover with you is the role of shared decision-making. You've heard me emphasize that a great number of times here, because there are some excellent options for these patients. As we mentioned, none of these things cure the patient. So getting their buy-in and therefore hopefully their compliance, that's going to lead to better outcomes. So this is modified from a shared decision-making decision aid tool that was developed by the American College of Allergy, Asthma, and Immunology and the American Rhinologic Society. And this is written in a language that patients can understand. So it goes over how each of the treatments is used, what are their advantages, what are their disadvantages. What's not seen on this slide is what type of outcome should the patient expect? When should they expect to see improvement? And very importantly, we know for our patients is cost. And is it covered by their particular insurance? So all of these are important options as far as determining, both in John and the other patients that we see, how they do with particular treatments related to chronic rhinosinusitis and nasal polyps. So this is important as we care for these patients. So with that, I'm going to move on now and move to our post-test polling. And here's our first question, and we'll see how the results happen. So patients with chronic rhinosinusitis, nasal polyps, and a relevant comorbid condition were up to how many times more likely to undergo at least one revision surgery during a 10-year window compared to patients without one of those T2, T-high comorbidities like asthma, NSAID, exacerbated respiratory disease, allergic rhinitis. So if I can have your answer now. All right. So this is great because if we look at the post, we can see here that we now have 40%, in fact, said the correct answer now, and that is 4.7 times, almost 5 times higher. Something we really have to consider when we're taking care of these patients if they have any comorbidities, because it really does increase the risk of repeat surgery. So, so I think that's extremely important when one is, again, evaluating and treating these patients and determining next steps as far as treatment. The next question. According to EPOS 2020, in order to meet the criteria for need of systemic corticosteroids in consideration of biologic treatment for chronic rhinosinusitis and nasal polyps, the patient should have which of the following? One or more short courses of oral corticosteroids or a long-term oral corticosteroid therapy for 1 month or greater. Or number 2, greater than or equal to 2 short courses of oral corticosteroids per year, or long-term oral corticosteroid therapy for 3 months or greater. And the last answer, 3 or more short courses of oral corticosteroids per year and long-term oral corticosteroid therapy for 6 months or greater. So if we could have your answer now. All right. So, in fact, the answer is 2 or more short courses of oral corticosteroids or long-term oral corticosteroid use for 3 months or greater. And you can see here the number that, in fact, got it right. A little less now from the pre-test compared to the post-test. But the bottom line here, that's the criteria that is used by EPOS And I think that's a valid criteria, because once you get more than 2 short courses, I really start worrying over time. Again, you get that accumulative effect of oral corticosteroids, and therefore you increase that risk of systemic activity. So I think that's extremely important. So our next question has to do with the patient, Tom, and he's a 45-year-old male with chronic rhinosinusitis with nasal polyps that's impacting his quality of life. He is currently taking medium-dose inhaled corticosteroids for comorbid asthma. He has been treated with exhalation delivery system Fluticasone for the past 6 months and was previously on daily intranasal corticosteroid. He completed 2 short courses of oral steroids after losing his ability to smell. His smell returned after each course, but subsequently faded. He is surgery naive. So what would you recommend as the next step for this particular patient? A short course of oral corticosteroids, exhalation delivery system Fluticasone, 1 spray per nostril twice daily, biologic therapy, or functional endoscopic sinus surgery. So your answer now. All right. So we have post-test, we have 83% biologic therapy, 17% functional endoscopic sinus surgery. Well, both answers, in fact, could be correct. I would tend to be for more biologic, but I think it's important here to go to shared decision-making. So I think Tom needs to know the benefits and risks associated with biologic therapy, and the same for endoscopic sinus surgery, and get an idea from him which, in fact, treatment he would, in fact, prefer. I do think, since he's on medium dose inhaled corticosteroid comorbid asthma, and we've been talking about the revision rate in those particular patients, I would tend to lead toward biologic therapy, ask my opinion, but I still think shared decision-making is extremely important. And the next question, a subgroup analysis of patients with chronic rhinosinusitis with nasal polyps and asthma and an indirect treatment comparison found statistically significant improvement in nasal polyp score and nasal congestion in patients with or without aspirin-exacerbated respiratory disease, and in nasal congestion in patients with aspirin-exacerbated respiratory disease for which of the following? Was it a comparison of dupilumab versus omalizumab, omalizumab versus mepolizumab, or mepolizumab versus dupilumab? So if we could have your answer now. Yes. So, yep, the correct answer, in fact, that the vast majority of you got was it was data comparing dupilumab and omalizumab. So with that, here's a summary of what we discussed this evening. Very clearly that this condition has an impact significantly on patient and economic burden. We mentioned about the multitude of questionnaires that one can use to measure quality of life in chronic rhinosinusitis with nasal polyps. Very importantly, we always have to remember about the adverse effects of systemic corticosteroids outweigh the advantages of therapeutic value in the long term, except in those very rare patients with severe symptomatology or treatment resistance. Consensus groups provide guidance on the selection of surgery versus biologics or other treatments for this condition. We went over several of those this evening. Presently in the United States, we have 3 biologics approved for chronic rhinosinusitis and nasal polyps. In the absence of head-to-head studies, as I mentioned, there are none at this time, an indirect treatment comparison may provide some support for selection of individual biologics in individual patients. We know that the presence of comorbidities like asthma or asthma-exacerbated respiratory disease should be considered, as we've talked about, in patients with chronic rhinosinusitis nasal polyps, because they tend to have more severe disease. And patients, as we mentioned, with chronic rhinosinusitis and these type 2 comorbidities have up to almost 5 times more likely to have to undergo revision surgery. So with that, I think we've got a few minutes out there before the end of the hour for any questions that you may have. So you can click on the question tab and type in any question you have, and I will try to answer those for you this evening. Don't be shy. Any questions or any comments, that would be terrific. Well, again, I want to thank you for joining me this evening. I hope you found the CMA activity helpful in your day-to-day practice, taking care of patients with chronic rhinosinusitis with nasal polyps. A lot of excellent options out there. We have a great deal now of understanding of the role of biologics. And again, I want to thank you for taking your time this evening and joining us. Have a good evening.